And good morning, everyone. Welcome to PerfWeb 103, Day 2. I'm your humble host, Joe Basha, and my guest host, who is always willing to take over when I'm not here, Dr. Samir Patel. Good to see you.
Thank you,
How are you
Joe?
this morning?
Doing well.
I heard you had fun yesterday.
I did. It was blessed.
Does everybody notice how happy I look that I'm just finding out today about all the things that aren't going to work today? No call-in number, no pop-up windows, nothing. Okay, we're going full. We're going backwards. We are
1965 all over
PerfWeb
again.
is devolving technologically just down into the abyss, the cauldron of confusion. That's where we're going. But we are moving the studio, as you all know. So as we continue to move to the new place, you'll probably see more and more changes in the short term until we get to where we need to be. So I need to do my opening remarks, but I was told to omit something from it. So first, to contact us, you'll just have to look at the scroll bar down below because we no longer have anything. I'm sorry? Yeah,
There it
scroll
is.
bar's there. Yeah, so you can use that scroll bar, and you can find all the information because we have no more fancy pop-up windows like we used to have back in the old days. Okay. We'll have it tomorrow. Okay, I hear we'll have it tomorrow. Then the call-in number, I can't tell you what it is. I don't even know what it is. And there is no call-in number, as I'm being told. We've already discussed that.
We're
Then
on-
there's the MediWeb app. I'm not even sure if it's still there anymore. Oh, look, it came up. The MediWeb app pop-up is there. Fantastic. Okay, it's $2.99 for the full app and only 99 cents for the smaller app. And actually, we're starting to see some sales of these things. You know, people are finally seeing it. It's only been 5 years. I think all of the information's probably since
There you
changed.
go.
You know, now with AI, you don't need this anymore.
No.
And we're going to have a lot of fun coming up on that program that we're
Speaking
going
of
to be
AI,
doing,
yeah,
where
with
we're
everybody.
testing our knowledge. And I actually got this idea from a guy that used to be part of our team, but has since moved on. But I thought it was still a good idea. And it's this game where you have this balloon, and you have these spikes, and you keep inserting these spikes, and it compresses the balloon, and it gets tighter and tighter. And so the way the game's going to work is you get asked a question, and if you answer the question correctly, well, you don't have to put a spike in. You answer it incorrectly, then you have to put the spike in. And as you go through this game, eventually somebody explodes the
balloon,
head,
yeah.
you know, the balloon head. And then there's our app. Go check it out. It's really good. And then I really recommend you get it. It really has utility. I use it, and I enjoy it. And, of course, it's mine, so I love it even more. You can imagine that. And if you're not going to buy it because it's actually of use to you, buy it just because you like me. I mean, I don't care why you buy it. Just buy the doggone thing. PerfWeb Podcast. You can go to your favorite streaming platform, and you can find us no matter which it is, and just type in PerfWeb, and you can listen to us online. And here's some of the things that we have. The PerfWeb 101 Day 3. Look at all that stuff. It's all on there. That's fantastic. I really like it. And so doing the podcasts is fun. All right, moving on from there. Couple of things. As you well know, NRP is becoming more and more commonplace. And there's a lot of people that are currently flooding into the space. Everybody sees the opportunity, or not everybody. Some people don't like it at all. I mean,
No,
okay,
right.
and that really is the difference between people that are basically either practice owners or they're managers or they're whatever the case may be, independent operators where they're looking to capture billable services, right? Because
Right.
that's how we make our
Right,
living.
right.
Healthcare is, in fact, a business.
Correct.
And we have to take that into consideration when we do these things. So with that said, a lot of people getting into it. Some people are getting into it and doing really well. Some people are getting into it and not doing so well. And I think we just had the THI meeting which I spoke at about this topic, as a matter of fact. And I think that it's going to end up being a basically a results-based industry. If you are doing good and the cases that you do have more organ utilization than not, because sometimes they don't do well. But if it's your fault, I think you'll just not get called for the cases.
Right.
I mean, I think that's really what it's going to come down to. It's
right.
going to become merit-based.
Yeah.
Some of it's personality, some of it's contracts, and we'll have to deal with all of that. But what's been your experience with the NRP? Like, what's your just basic thoughts?
I've enjoyed my experience thus far. I think the experience with results and outcomes has a lot to do with the experience of the team that is conducting the organ procurement, and not just the NRP team. I'm talking about the whole team.
Yes.
If you got inexperienced surgeons up there, it can really make your NRP run really hard.
Well, and then when you have more than one team
Exactly.
messing around in the space,
Right,
because you have the heart team, the lung team, you have the liver team and kidney team together, and people are fighting over what's getting clamped, when it's getting clamped. It's not as cohesive.
No.
But I think that is not uncommon within the organ harvesting world, even when it was just straightforward DBD, right?
Right.
So I don't think that's necessarily, hey, Magic, could you check your text? I don't think it's uncommon for that to just
happen.
be a problem.
Right.
But with that said, what about, since our conversation today is going to be about ethics, of which it just says presentation title. I've just completely messed these slides up. It's really sad. It's a sad state of affairs. Nobody's noticed that, but it'll be good. It'll be good. I can make the title whatever I prefer for it to be.
There you go, on the fly.
And exactly, on the fly, exactly. So with that said, what's your thoughts on the ethical quandaries that are existing with this?
I mean, I think because it's new, people,
David,
ethics. Ethics definitely come into the picture. People don't understand what we're doing. A lot of people are so caught up with recirculation and are we bringing them back to life? Because again, this is new and we don't really know. There's the whole quandary of, the brain, it shouldn't get blood. Oh, well, is the clamp proper? Are we circulating the brain? Are we sure the clamp is on right? Specifically, if you're using endo clamps, is it clamped? Is that balloon inflated all the way? Are you preventing circulation to the brain? Then of course there's the whole, was the patient's family properly explained? When we were taking consent of what's actually going to go on. Again, Joe, this is all new, so I can understand where some of the arguments come from, and I think that over time, a lot of these arguments, to me, they don't hold much water. Sure, the consent thing can go either way. That's completely based on the person acquiring the consent. How much did they explain? How much did they not explain? Of what actually is going on? That can vary center to center.
Thanks, David.
That will never, that's completely dependent on the person that's acquiring the consent. So that is a wash to me. But things like, the recirculation of the brain, recirculation of the organs, is this ethically sound? Should we be doing it? Are we creating Frankenstein monster organs? I think that's just all because it's new. To me, that's what I believe.
Well, I hearken back to a time many, many years ago, and for those of you who remember Baby Faye, for those of you who don't, you can look that up. And of course, it was Dr. Len Bailey out of Loma Linda who transplanted a baboon heart into a small child as a transplant option. The child was not doing well and was going to die. Now, ultimately did die, but in talking with Dr. Bailey, who's since deceased, but probably one of the kindest people I've ever met, him and his wife both, Nancy, they died within a week of each other, one from ovarian cancer and one from throat cancer.
Oh, no.
And yeah, I know, it's very tragic. It really is.
And the
it's
likelihood
interesting.
is so slim to none. Like that's
I know.
that's
And
horrible.
the fact that he had operated on so many babies. I mean,
Yeah,
he had done
pediatric.
500 or so heart transplants on babies. Pretty impressive career this man had, and along with a whole lot of other procedures. But I'm talking just straight transplants.
Sure.
And in babies, and as a single surgeon experience is pretty impressive. But him and his wife never had children. They had adopted children, never had children of their own, which I thought was very interesting. But he was well revered. He was revered in Loma Linda. He really was. And like I said, he's one of the kindest people I ever knew. But after Baby Faye, he could never receive mail at his own home because of the animal rights people. And if you go back and look at the news reports, even Ted Koppel was calling him just really terrible names, and which led to a lot of people really being hateful towards him
Sure.
and throughout his career. So ethics in medicine is not something that is all that foreign
Right.
to everyone. So
Right.
with that said, let me go to slideshow, presenter view, and let's go ahead and go with my slides if we can. So
Did you add that title,
get into
or was
this.
that another title, or
I added it.
nice?
I mean, y'all didn't think I could do it, but I told you could. The reason you couldn't do it is because you weren't logged into the account. But
That
that's a
explains
different
it.
issue. Yes.
Yes.
So it gives you limited functionality.
Right.
Right.
It takes your keyboard away.
Exactly.
Oh
so
my God.
So let us go through this here. Ethics in NRP, normothermic regional perfusion, and I am Joseph Basha, or Joe Basha. I'm a perfusionist, certified ABCP originally in 1980, and that was my first time being certified. We won't get into that discussion, but nevertheless, have been practicing since my graduation, June of 1979. Went to the Tucson Heart Institute, which was the second accredited program in the country, accredited perfusion training program, second to Texas Heart
THI,
Institute.
yeah,
And
yeah.
our director, Billy Applegate, was very, very close friends with, of course, Charlie Reed, the founder of the Texas Heart Institute, the first and original accredited perfusion training program in the country.
Right.
So actually the world,
Right.
to be frank. And both gentlemen were quite impressive and knew a lot, and each was in their own way savants in a way. They were very eclectic in their nature and did a lot of very interesting things. So I feel like my experience in perfusion school really did prepare me for where we are today. And I think the training today is vastly different than it was at that time, which is both good and bad. I see both sides of it. But anyway, getting back into ethics, this is a common theme in really life. Ethics is ethics in healthcare, ethics in politics. There's ethics in science. There's ethics in everything, right? And we have to take that into consideration. So we cannot forget, and what these two pictures represent is the woman on the left is holding her husband's hand and recognizing that a decision has been taken to perform NRP. This patient is not quite brain dead, and we'll talk a little bit about that here as we move forward, but he is going to die, and she has consented to allowing this process to take place for the purpose of harvesting his organs. And on the right is a patient who is getting sicker and sicker and sicker and needs these organs really, really bad. Now, the organs from the person on the left did not go into the person on the right, but they just are representing the fact that there are, at the end of the day, people, human beings with families, loved ones, who are on two sides of this coin. The one that is giving up their organs and the one that is praying to have received said organs. And we cannot forget that is the whole reason we are here. We are here for the compassion that we can provide and the ability to to have a family member feel that the life of their loved one had such a higher purpose that might not have ever been recognized even while they were alive, and give them some level of comfort at what is ultimately a very sad time.
Correct.
And then the people on the right, of course, they are praying, and they're conflicted. These people are very conflicted. People that receive organ transplant, though grateful for having received it, go through a lot of psychological trauma because they know somebody had to die. Unless we're talking about living transplant.
Right.
But that's not what we're talking
No,
about.
right.
But those are very touching stories as well.
Right.
These are two incredible tragedies that are taking place. One ends well, and one ends poorly. But we try to mitigate the poorly of it.
Correct.
The poorly aspect of it. So there's some terms that I want to go through and the purpose of them. All right. So you have first DCD. It's basically just stands for donation after circulatory death or cardiac death, whichever you prefer. You also see it with little c DCD, which just simply means controlled donation after circulatory or cardiac death. So you'll see it expressed the same way. So when you do see that, you'll know what it means. It's not some magical thing. It's just controlled is what that preceding C means. DBD, which is donation after brain death, is very easy, and all of us already are very well aware of what that actually is and means. It's commonplace. It's been going on for decades now. So it's a common theme. Everyone's familiar with it. OCS is Organ Care System. And currently, now there's a new one out, Organics, but Transmedics out of Andover, Massachusetts, right? Yeah. Is the company that has the original organ care system, and that's the heart in the box, the lungs in the box, the liver in the box.
Right.
Okay, exactly. And then you have NRP, which is normothermic regional perfusion. And this technique has not been around all that long, really only about 5 years.
Right.
And we have had on this program, hopefully again we'll have, who I consider to be one of the world's foremost authorities on NRP technique, Matt Warhoover, he's out of Tennessee, out of Nashville, but he is who has introduced this to us. He did a program on it. I was extremely interested. I thought this was just incredibly revolutionary, and what a concept. And the whole point of NRP is to bridge the divide between DBD and throwing the organs away. Right? So DCD is born out of the fact that there are a lot of patients who are brain dead who donate, and you have DBD, donation after brain death. Very easy for all of us to understand. Again, not to harp on the issue, but I just want to make sure I stress it. But if you're not all the way brain dead, you don't meet brain death criteria, those organs have been thrown away. And when you look at the numbers, which is not the purpose of this lecture, the numbers are quite staggering at how many organs are discarded simply because the patient did not quite meet brain death criteria, but they were nonetheless very dead. And then you have the timeout period. You'll see that frequently. And timeout period is basically from the time that heart has stopped in an NRP case or a DCD case, and we'll go over the process a little bit, but the heart stops, that starts a timeout period. 5 minutes here in the United States, though they're trying to push it to 2 minutes. And that's going to be a real challenge. I don't think that's going to happen. But nevertheless, you have a 5-minute timeout or standoff period. And that is the time where you're waiting to see if the heart will auto-resuscitate. Because remember, the heart has to stop.
Right.
And there have been occasions where it has auto-resuscitated.
Right.
But then it will stop again.
Right.
But you still cannot be touching these people if they have any cardiac function at all that you can hear. Now, if you have PEA, that is acceptable, just as acceptable as asystole. So if you have PEA, that's fine. The agonal phase is the time where the blood pressure has reached 50 or below 50. I think it's below. It could be 50 or below. I can't really quite remember.
I think it was below 50.
Below 50?
I saw it on some paperwork the other day. It didn't
Below.
have, yeah, we didn't have like an equal sign, lesser than equal.
Below
It's
50,
below
exactly.
50, yeah.
And that's considered the agonal phase. Now, if the blood pressure falls to 48, bounces right back up again to 52, and stays there for 2 or 3 minutes, and then back to 48, it will be the transplanting or organ receiving facilities or program or clinicians, providers' decision whether to restart that clock or not. And that's how that process works. And then you have the warm ischemic time. That is the time that the agonal phase begins until either NRP is initiated or the organs are flushed and put on cold storage. And there's a difference between those two. One is still going to be ischemic. The other is going to be considered regenerative for the particular organ or organs that you are trying to recondition for evaluation to be transplantable, suitable for transplant. Okay, so that's these terms. Which brings us in the ethical conundrum that we've been discussing here, that's right, DDR, the dead donor rule. And this is very, very important.
Right. Yeah, it drives the whole
Correct.
question of ethical in this.
Correct. The dead donor rule is an ethical norm related to decreased organ donation that is often expressed as organ donors must be dead before procurement of organs begins, and organ procurement itself must not cause the death of the donor. So you need both of these things. Which then leads us to what is death?
Exactly.
And why do we insist on the DDR, dead donor rule? And this is very important. What is death? And that can be both objective, but it could also be very subjective.
And it can vary from country to country.
That can do that too.
Yeah.
Do you feel right? What you believe, well, I think really what it comes down to is I wouldn't ask the question, what is death? That isn't what I would ask. I would ask, what is meaningful life? That's how I ask the question for myself.
Correct.
But that is subjective. You have to, you cannot introduce subjectivity to this argument. It purely has to be objective.
Right.
And so it's a very complex problem. But because we all have our viewpoint of what is meaningful life. You could have a loved one laying there in essentially a vegetative state, completely incapable of doing anything for themselves. But if you are that person's mother or father or brother, or what it could be a parent, could be anybody, they are your loved ones, you may view that life as meaningful to you. Not necessarily to them, but to you, because you are caring for them and they are still with you, even if it is in this condition. Maybe they just can hear one thing. They know you're there. They can't communicate, but they feel you. You don't know what goes on in people's minds. And this is a very, very deeply emotional, very complex issue. So what is death? According to the American Journal of Bioethics, a process or a specific declaration. It is a biological continuum of events or a decision based on medical, ethical, and legal criteria. So these are questions it's asking. So let's do that again. What is death? Is it a process or a specific declaration? Is it a biological continuum of events or a decision based on medical, ethical, and legal criteria? In the view of the authors, it is both. And there are philosophical and theological, but also very pragmatic reasons why the problem of death puts our ethical concerns to the test. The procedures of organ donation, either following brain death or circulatory arrest, reveal a critical need to discuss, to define, and sometimes even to jeopardize our judgments and sensibilities on the issue. Now, I read this article 4 times. And I got something out of it 4 times. Something different out of it 4 times. I highly recommend it. It's very easy to find. You can just type the title in, and it pops up on the interwebs, and you can read it. But I highly recommend you do. It's worth it. So organ harvesting process. Well, you have living donors, but we're not talking about those. But nevertheless, listen, I need your kidney, and your kidney's a match to me. Would you be willing to give it to me?
Right.
And your answer would be?
Mine?
Yeah.
Absolutely. You can have
I was hoping you would say no.
I'm not going to say no. I believe you only need one to live. I would give it.
Unless you end up with CKD in the one you have left.
This is true.
I don't think that's a good idea. Then you need a living. I go back and say, I need that kidney back. Indian giver, okay? Then you have DBD, and that's terrible to say Indian giver. That was American Indian giver, not Asian Indian giver.
Sitting next to an Indian talking about Indian giving.
Just terrible things. Terrible things. I'm a racist. What can I tell you? And then you have the DBD. We talked about that. A DCD, sometimes seen, and the process to bridge the divide of brain death and essentially unrecoverable. So DCD, after a donor is identified and consents are signed by appropriate representatives. So we're going to kind of go through what the process really is in a simplified form. It's far more complex than that, but we're just going to keep it simple, okay? Patients taken to either the operating room or to the PACU. It's preferred the operating room because if it's in the PACU, from the time the heart stops, you now have the first time. And by the way, it's the second validation, the second verification the heart is still stopped is then considered the time of death, the actual time of death, not the first time.
Right.
Okay? But you have to rush them down the hallway to the operating room
5 minutes.
and start prepping them. And if they if they happen to auto resuscitate, you have to turn them all the way and go back. It's not very much it's much more preferred in the operating room, and they do this very, very well. The operating room, they are put on the table, they're prepped out, they're draped. Everything is then covered with drapes in the room. The patient's head is exposed, an arm is exposed for the family to have touch, comfort through touch, and it's done in a very, albeit an operating room, much more sensitive or less clinical way. It is an operating room, so you lose that maybe because of the basic environment, but it is done in a very, what's the word I want to use? Sensitive way and a compassionate way. That's kind of the word I was looking to try to use there. So then at that point in time, before care is withdrawn, a lot of heparin is given and comfort meds are also given. Then care is withdrawn, and the time from care withdrawal to death can be hospital policy, 60 minutes, 90 minutes, 120 minutes, and possibly longer. And there's reasons why that can happen, but each hospital has their own time limit. And that is for only the reason that they don't want their operating room occupied by you all day in order for this to occur. So that's, again, a hospital policy. The agonal phase occurs from the time the systolic blood pressure is less than 50. And I want to go back to this 60, 90, or 120 minutes.
Okay.
That is from the time of either extubation or turning off any medications, whatever the case may be. It's when care is withdrawn completely is when that clock starts. Not from the time you get in the operating room, but from the time care is withdrawn. Okay. The agonal phase, we talked about that, systolic blood pressure of less than 50, and that is also referred to as the warm ischemic time. Then the heart stops. There's a 5-minute standoff, no touch, and we are all, at the time the care is prior to care being withdrawn, anyone on the NRP team or harvest teams, everyone, is segregated in a completely different area, not seen, not communicating with the family or anywhere near the patient. We are completely removed from that process, and that is for ethical reasons, right? And also for image. You know, it would look really terrible for us to be standing in the corner like a bunch of vultures, waiting for this these people's loved one to pass. So there's a lot of reasons for it, but it also is a legal kind of requirement. I do want to talk about the Italian experience. We are at 5 minutes of standoff, and we want to go to 2 minutes, some places in this country. But the Italian experience is very important because they have excellent results, and they wait 20 minutes. 20 full minutes. From the time the heart stops to the time they check again to see if the heart is still stopped, and then they start with the procedure. So whether you're talking about 5 minutes, which I think all of us would agree, if your heart stops at normothermia for 5 minutes, no blood flow whatsoever going to your brain, you will in fact be brain dead. I think everyone, we understand it from science. You have to have some other factor involved in order, like some immersion into freezing water.
Correct.
There has to be some other element.
Something to decrease the metabolic demand of the brain.
Correct.
Right.
But 5 minutes, I think we all agree. But so if you wait 10 minutes, 20 minutes, 7 minutes, 12 minutes, 15 minutes, I don't think there's anybody on this in this group or anybody watching in our audience that would not pretty much agree. Yeah, they're not coming back from that. There's no way they're going to come back from that. But nevertheless, after 5 minutes and reaffirmation that the circulation has in fact not been restored, this is considered the time of death. The death is declared for legal purposes, and then the incisions and the process from that point forward begins. So controversy over what? 5 minutes without a heartbeat, you are definitely dead in my view, and I submit your view.
I would agree. Yeah,
and a lot of people. So the fundamental question is, what is life versus what is death? What could go wrong here? I mean, it just seems so incredibly black and white or red and white or obvious to all of us what could possibly go wrong.
His daddy can't talk.
Look who knows so much, huh? Well, it just so happens that your friend here is only mostly dead. There's a big difference between mostly dead and all dead. Please open his mouth. Now, mostly dead is slightly alive. Now, all dead, well, with all dead, there's usually only one thing that you can do.
What's that?
Go through his clothes and look for loose change.
From The Princess Bride, for those of you who haven't seen the movie.
Good movie.
So what could go wrong? So a man was declared dead and almost had surgery to donate his organs, but he was still alive. This was published. You'd have to look it up. I don't have the reference to where it came out of NPR, Health News NPR. The procuring surgeon, he was like, I'm out of it. I want nothing to do with it. It was very chaotic. Everyone was just very upset. Miller says she overheard the case coordinator at the hospital for her employer, Kentucky Organ Donor Affiliates, which is an OPO. The OPO is an organ procurement organization. You'll hear all of these things. Call her supervisor for advice. The coordinator calls the supervisor at the time, and she was saying that he was telling her that she needed to find another doctor to do it. This is the surgeon who was refusing. That we were going, and the supervisor said, we were going to do this case. She needs to find someone else, another physician, Miller says, and she's like, there is no one else. She was crying, the coordinator, because she's getting yelled at. So this was basically just quotes out of it in the report. Mm-hmm. But here's the issue. The guy on the left and the man in the picture of the wedding is the patient. Mm-hmm. Mm-hmm. That is the patient. Mm-hmm. So what could go wrong? Seemingly a lot.
Yeah.
Can go wrong a lot. Like, this is like, whoa.
Yeah, exactly.
Whoa. And this has turned into quite the story.
Okay.
You can find this online. Mm-hmm. In fact, if you go online and you just look up organ donation and whistleblowers, mm-hmm. and it'll populate a whole bunch of stuff that you can review. It's very, very, very interesting.
Okay.
Mm-hmm. It's incredibly infrequent, but it's incredibly unsettling that it happens at all. So once is enough for me.
Sure.
Concerning.
Yeah, absolutely.
Because I've asked myself, what's the controversy here? What are we talking? Why are we having this discussion? They're dead.
Right.
I mean, they're dead. You can look at them. That person's dead. You know, I know what a dead person looks like. Probably everyone in healthcare knows what a dead person looks like.
Right.
Right. They look dead.
Yeah.
Right. But it isn't necessarily about being dead. Here's where the sticky wicket is. Mm-hmm. If you remember what I said, they come to the operating room. They're given comfort medicines.
Yep.
Heparin, comfort medicines.
Yep.
And care is withdrawn or extubated.
Right.
Let's say they're breathing over the vent. You give them the comfort medicines and you depress their respiratory drive.
Right.
Or they have some other, issue, maybe some obesity, sleep apnea.
Right.
And they obstruct their airway. And they might not have died.
Had you not have given all that.
Had we not done that. And if you remember the dead donor rule, the organ harvesting, and that doesn't mean opening them up, cutting the organ out. It's a process.
It's the whole process.
Cannot be the proximate cause of the person's demise.
Right.
Very complicated problem.
Yeah, very complicated problem.
The ethical part of that, I always thought to myself, what's the ethical conundrum here? What's the problem? Why are we having this discussion? They're dead. Mm-hmm. But then I started looking into this and I started really thinking about it. I'm like, oh no. But we might have killed them.
Exactly.
That's concerning.
That is
right?
concerning. Absolutely.
Very concerning.
Yeah, very concerning.
I think extremely rare.
Right.
Incredibly rare. And of course, there are horrible people in this world. I mean, it can happen, mm-hmm, right? Mm-hmm. I think that the perfect example of that is this issue in Kentucky.
Right.
Find someone else to take the damn organs. And this dude was clearly alive. He got married. I was on my way back from a case. I can't remember what day it was. It was yesterday or day before yesterday. I can't remember anymore. And I was talking with one of the surgeons that does harvesting. And she was telling me about, because I was telling her I was going to be giving this lecture. And she says, well, I was doing a case not too terribly long ago. And the patient was brought in, and the nurse walked over to me and said, "Are you the harvesting surgeon?" And she said, "I am." And her entire demeanor changed, and she stared at me, and she said, actually, it's longer than a few days ago. The case was, let's say, several months ago, really. And she looked at me and she said, "They're not going to die," real angrily, just angrily at me. And I'm like, oh, okay. I kind of got taken aback, and I was like, okay, I understand. Person has an emotional, feeling about this. Patient was given comfort meds, given heparin, was on OR table, prepped and draped, family at the bedside. There's the comment of the nurse that she's not going to die. What could have happened instead? Well, she told me what happened. Patient didn't die. Patient went home.
Really?
Under their own power. Not unlike this person.
Not like, yeah, exactly.
Not unlike it. This was going to be a DCD case. Now, just try to imagine having given the comfort meds and that person obstructed their airway and suffocated because of it, given fentanyl, just drove down their respiratory drive, and they died from asphyxiation.
Right.
They didn't need to.
Correct.
And that unsettled her too. So I do think this is an issue that has to be looked at very, very carefully. And I do believe that we have got to come up with as stringent a safe level of safeguards, a stringent level of safeguards that we can to really nearly eliminate, and I don't think you just can eliminate anything completely. I don't think there's absolutes.
Yeah.
There's just no absolutes.
No.
So we have to be able to, but we really have to have some very hardy safeguards in place in order to be able to do this procedure, DCD. DBD is easy.
Right.
DCD, far more complex.
Yeah, much more complex.
Much more complex.
Yeah.
And so I'll leave you with this. Barbie sees Ken for the first time and realizes that this may make for a very awkward night. That's kind of my view of DCD. All right, so let's discuss it. There are my thoughts. Your thoughts?
I think that, especially given these last two cases that we discussed, we need to really look at the process, the criteria that need to be met for DCD or a controlled DCD. I mean, how do we know that the patient, if that nurse was so sure that the patient
It was
wasn't,
the ICU nurse taking care of it.
and if she was so sure that the patient wasn't going to die, then how are the doctors not as sure? And why did we withdraw care? Do you get what I'm saying? Like it's clear that that patient didn't need to have the care withdrawn.
Exactly. But let me tell you this. Let me go. I forgot.
Like, how did he even get to the operating room?
I forgot to tell you this. Exactly. Walked. I forgot to show you this. I forgot to go back to this person here. This slide. Throw that up again. Yeah, thanks. What the nurse saw in this patient that caused all of this to happen was they were crying.
No, see,
They were crying.
That implies a very high GCS score.
The patient was crying. That's what the nurse saw in this particular case.
Yeah, no, that's see, Joe, this is what I mean by.
Thank you.
It's not even. People are attacking the end of the process, you know? Maybe it's not the end we need to be looking at, but even before they get into the operating room. Maybe this process needs to go back to step 1. Quit worrying about step 10. Yes, the comfort meds is a problem. Absolutely. Okay, and I agree with that. Maybe, they need to look at that as well, but more importantly than that is how are these patients even reaching the operating? How are they even getting to the point of deciding to withdraw care?
Yeah, on a
patient that can recover.
On a donor list.
On a donor list. How are they even going to step 2 and then convincing the family?
Right.
That your loved one's not going to make it you know.
Exactly. We should have, you're absolutely right. I agree with what you just said. You're 100% right. We in the operating room should not be where we're worrying about this.
Exactly.
We should be able to focus on what it is we need to
Exactly.
do, which is restoring the organs to a point of being suitable for transplant to somebody
Exactly.
else.
That is not, like you said, it shouldn't be our problem. We have our own problems to worry about, comfort meds, things that we do, right? Like, that is our problem. You know, comfort meds is something that we need to look at because it's involved in our step. But what, like you said, this is like ICU docs problems. This is a problem that way before we're even involved, we shouldn't even be involved.
Agreed.
You know, like, it shouldn't even come to us. This should not even be in our
Agreed.
operating room. It should not even be a thing.
Once they make it to us, all of these questions should have long since been answered.
Exactly.
And I find that to be problematic, right?
I find that to be it's
There's-
alarming.
But at the same time, there's nothing more frustrating to me as a clinician who is there for a purpose. My purpose is to take organs that have been insulted by the dying and death process post-mortem
Correct.
and
Very important.
to
Post-mortem.
turn those organs around so that they function again and can help, you know, as many as, in terms of living, truly living, as many as 1, 2, 3, 4, 5, 6, 7 people minimum.
Right.
7 recipients minimum, the potential for that.
Right.
Sometimes we're only there to get liver, kidneys. Sometimes we're there to get liver, kidney, lungs. Sometimes they're there to get just heart.
Right.
But that's rare. But
Right.
nevertheless, there's a lot of things here. You could maybe only use certain organs of a donor
Correct.
that are suitable. But then you have skin, you have all the other things that are really important to a lot of people as well.
Right.
But just for, you know, really people that are in life and death
Mm-hmm,
situations and in a moment, that's what I'm there for.
Exactly.
And there's nothing more frustrating than to do these cases and not have them go well and
Exactly.
have the organs able to be used.
Yep.
Because the amount of work that we do to get just to the point of beginning this process
Correct.
is incredibly intensive.
Right.
And it's incredibly emotionally draining.
It is.
And so I know that somebody's coming in, and it's you know the family's going to be in there around their love. You can feel from
feel
a
it.
completely different room.
You can
all
feel it.
of that
It's palpable.
emotion.
You can.
And then we go in there and do our job, and it goes poorly, and none of the organs are usable. There's nothing I can think of that's more frustrating than that.
Yep.
Because again, it's a lot of work and a lot of emotional strain on us just to get to the point where we're able to do what we are literally there to do.
Yep.
Which is this teeny little piece
Yep.
of an entirely big giant process.
Yep.
That's our focus right there. And when you walk away and failed at that,
Yep.
you've not only have you had a life that doesn't have for the family the benefit of feeling like there was a true purpose to this person. We don't know all their stories.
Right.
But we don't help all those other people either
Exactly.
that could have benefited from it. And
Yeah.
you take it incredibly personally.
Oh, yeah.
You know? And if you don't, you shouldn't be doing this.
No, I mean, yeah. I mean, if you're operating without feeling, then and working in the healthcare industry without any type of compassion or feeling, then you shouldn't be in the healthcare industry.
Agreed.
That is, I feel, a requirement. You know, compassion, stuff like this is it's one of the things they'll tell you. Any type of hospital you get hired on, any type of introduction meetings that you have, or like the very first thing, they'll make you watch videos about compassion and this and that because it's like a core requirement of what you do. Mm-hmm. So why are you in the industry if
Can
you're not
you
like
teach
that?
somebody compassion?
No, of course not.
I don't think so.
Of course not.
I don't think so.
You absolutely cannot.
You either have it or you don't.
either have it or you don't.
You
And-
might
and-
be able to be taught how to express it,
Exactly.
Because some people have a hard time with that.
Right. Some
But-
people are compassionate and they can't express it. Some people are not compassionate but can express compassion,
Which is really
which
sad.
is sad.
I think you
That's
better
just-
be compassionate.
Yeah.
Or get the hell out of healthcare, because this is just you got to have it.
Yeah.
But you also have to be able to segregate it.
I agree.
Because if you didn't, we
It
would
can-
be complete wrecks. We would be
Yeah,
ineffective.
You can't, yeah.
You know, and
especially if you're like in perfusion or in the OR or working in an ICU where death is common. You know, it can happen. You can't let it wreck.
Can
you.
happen.
It can't. It
it happens a lot.
Yeah, it happens a lot. And you can't let it wreck you. You might have another case. You might have another patient. You know, you
Yeah.
can't. You need to compartmentalize.
You do.
need
You have to accept it for what it is.
and move on and try
Agreed.
to care for the next guy. You know, with the same level of care you provided for the first guy.
That's
know?
right. That's
So-
right. You're exactly right. Yep. Okay. Well, that was excellent. I do
Yep.
want to discuss a little bit about what we're doing here moving forward. So tomorrow morning, we're going to be doing new technologies in organ preservation. That's going to be me again. And I want to discuss some of these different things, the organics, the OCS, some of the other cold storage devices.
Okay.
Because obviously we do things like cold static storage on ice,
Yep,
right? And
yep.
you just throw it in an ice chest with ice all around it, and
Yep.
you have to be concerned about possible frost burn.
Yep.
There's a lot of different things you have to do, and they're coming up with ways of trying to maintain the temperature of these organs very homogeneously and consistent at a temperature.
Correct.
And of course, one of the things that I was discussing the other day was the Vanderbilt experience. They now have an experience of a 7.5 hour post NRP static cold storage transport of an organ from far up Alaska all the way to Nashville,
wow.
reimplanted into a recipient, and the organ did fantastic. And I think that I'm going to take a little bit further than just the idea of the machines or boxes or whatever. Going to talk about something else too, and that would be the preservation fluid. Because now that we see what Del Nido is able to do,
Correct.
to go from the St. Thomas solution or the Buckberg solution
To Del Nido.
or to now Del Nido, where we used to be only maybe 10 minutes. Are you
Yeah.
kidding me? Was the max, man.
really?
You wouldn't go longer than 10 minutes without
Really?
giving. Oh my God. Yeah. Back in the old days.
Okay.
No, you weren't going 15, 20 minutes or anything like that.
Not
No.
like with some of the newer
No.
Plegisols and
Even
stuff like that.
Plegisol. You look
Yeah.
at some of the surgeons, some of our best surgeons. Mark Batoyer, for example, and he's 10 minutes, man. Like 10 minutes, he's giving another dose. He has incredible results, and you rarely ever see him with any kind of stunned myocardium, either right side, left side, or anything else. He's very, very careful with his cardioplegia administration and delivery times and where it's going, and making sure that if the right is of question, whether or not that's going to get protected, that's the first graft that gets done, and he's giving it down the right. So he's very, very cautious with myocardial preservation, which I appreciate that with him very much. But still, you can give Del Nido and get away with as much as 90 minutes. One
Right.
dose,
Yep,
90 minutes.
yep.
Now think about a solution that you could give that would give you 4 hours,
Right.
right?
Right.
So you have 4 hours plus you have a box that's at 4 degrees or 10 degrees consistently, and the organ's never getting any warmer than that. How far can you really stretch that out? So these devices like the OCS, which are supposedly there to extend this time, which really don't. And there's some other complications associated with it, or limitations that may be not complications. There's always that, but limitations to the technology. I think as you see preservation fluids changing, formulations changing, temperature management changing, you're going to see that 4-hour rule of explant to reimplantation
Right.
getting longer and longer and longer.
Right.
And I believe that that's going to result in NRP being even more popular than it currently is.
Correct.
So that is my belief on that.
Right. Yeah, I agree with that. Especially with the whole evolution of, like you're saying, organics or
Organics. Yeah.
And
organox. Yeah, that's how you say it. I got the emphasis on the wrong syllable.
There you go. It'll definitely, help with longer transports and stuff like that, and open up people to getting more organs, right? That current 4-hour restriction, it leads to a lot of people that are really in need not being able to get it simply for geographical reasons.
Correct.
Correct. So
I mean, there's been consideration of taking and moving the patient to where the organ is.
Yeah, I've
it's
heard about
impractical.
those. Yeah.
Impractical.
They
But
do
I
say
mean,
that.
there's a lot of things like that
Right.
that have been considered, you know,
Right.
and just found to be logistically impractical.
Exactly.
However, I think we're at a place now where, again, I think the preservation fluids are going to be game changers.
Yeah. And
Game
there's been,
changers.
like you said, there's been massive strides in only the last 15, 20 years,
Absolutely.
in these fluids. Like you said, back in the days, like 20, 25 years ago, where you're talking about Buckberg, St. Thomas solutions, stuff like this. It wasn't that long ago, And in that time alone, we've taken solutions from 10 minutes, like you said, to 90,
Yeah.
And if that's what, and technology and research is only progressing faster now than it was then. So,
Absolutely.
so maybe in the next 10 years, we'll get that 90 up to, 180 or maybe even farther,
Absolutely.
So-
Well, I mean, it's been 75 years, I think, somewhere around 75 years since the first successful use of extracorporeal circulation.
Yeah, see?
It's been 75 years.
Yeah, that's crazy.
Take into consideration that, now, interestingly enough, it's been how many years? Transplants have been around since the mid-60s, 70s,
that's
right?
been a while. Correct.
Mid-60s, 70s,
Correct.
yeah. And so some things have advanced incredibly fast and others maybe haven't so much. But if you, and of course, there's a lot of political and economic factors that are involved. But if you just look at it from the perspective of 500 years ago, you would agree that we lived in a rather barbaric society,
Yes.
right?
Yeah, for sure.
And look at what we have done in 500 years.
Exactly. And
Imagine
again, we're only
what-
moving faster now.
And yes, and that's the other thing, exactly.
Yeah. Maybe too fast, some would argue. But yeah, we're moving fast.
Possibly.
Yeah.
I don't know. But certainly, I think that the capacity for the human species to advance technologically, I don't think has even come close to being realized.
No, yeah, I
And
agree with that.
the world will be a very, very different place in 500 years or 1,000 years, if in fact our species continues to exist and we don't just,
Yeah.
don't exist anymore for whatever reason. Okay, we'll see you tomorrow morning, bright and early. Before we close out, I know that these times are dreadful, but here's my problem. We schedule a program for 9 o'clock in the morning, and I may have to rethink this, right? For 9 o'clock in the morning, 10 o'clock, 2 o'clock, some convenient time, civilized time. And I'm doing a case, or he's doing a case, or the person isn't available for clinical reasons. So I'm like, okay, I've got a brilliant idea. I loved it when I said that. I said it in front of the mirror.
Such a brilliant idea.
I have a brilliant
Let's
idea.
start at 5.
We're going to start at 5, and we're going to start at 8 at night. The very first program at 5 in the morning, and I'm somewhere else on a jet flying to go do some NRP case, or I think we were coming back by then,
Yeah, you were
and
coming back
completely
by then.
unable to do this. And I'm like, what the hell? I can't
can't
ever
win.
get it right. I
You
can't
can't
win.
win.
Anyway, we'll see you all tomorrow. Thank you for joining us today. Don't forget to please leave us our comments. Please like, share, promote. Please, please, please tell everyone how incredibly great and talented we are here at PerfWeb.
Absolutely.
Thank you.
And we are.
It's good seeing you again.
Good seeing you
Thank
again.
you.
Welcome back.
Peace out.
Bye.